Hello, we're going to discuss the case that for almost all the regeneration cases, it takes about 8 to 9 months from start to finish. This case, we use this surgical technique that we can do immediate implant placement and regeneration at the same time, and we could finish this case in about 4 months. Patient referred to our office for implant placement on number 19 and number 20 area. As you can see, on the CT scan, you see the existing bridge there, and this bridge needs to be removed. It's an old bridge. There's a cavity underneath, and our plan was to place 2 implants on that area. But based on the CT scan data, we notice is a severe horizontal bone loss on number 19 and number area because of the long-term edentulous tooth loss there. So for most of the time, what we do is we're gonna go stage this procedure. Stage 1, we're gonna do bone regeneration, wait for 5 months, and then come back. We place an implant, wait for another 3 or 4 months, and then we finish the case in about 8 to 9 months. But because of the anatomy advantage that we have on this case, as you can see on the cross-sectional images, we are able to do both of them at the same time, immediate implant placement and horizontal bone augmentation. What we usually do is, with the severe horizontal bone loss, when you place an implant, you have multiple of the thread exposure of that area. As you can see in this case, because of the good anatomy, is a wide body mandibular base, we are able to place an implant and do the bone grafting at the same time. Why? Because on these cases, when you place an implant, you have a primary stability to secure the implant, and also you can do the bone augmentation on that area. So our game plan for this case is we obtaining the CBCT. As you can see, I can do like a virtual placement of those implants. As you can see, this half of this implant is outside the bony envelope. That's number 19, and number 20, you can see it here, even more severe bone loss on number 20. As you can see, about like a 60% of the implant is outside the bony envelope. So our goal is to create that bone deficiency with our surgical technique. So what we do is we're gonna obtain the intraoral CT scan from the patient. So we have cone beam, we have intraoral scanning. We're gonna merge this together for digital planning. So for the digital planning, what we can do, we can come up with a surgical guide. So our surgical guide is to calculate how much bone. As you can see on the axial images of this CT scan, you see we do the measurement here. We need about 27 millimeter of the length of the block graft to repair that bone deficiency on the lower left side. Compare this to the right side. There is a bone there, everything is good, and we need to use that block graft for bone regeneration. So where that block graft come from? It will come from the retromolar area. If I pull back here, as you can see, this is the cross-sectional images. I can show it to you. This is our availability of the bone in this area for bone harvesting. So this is a sample of the bone harvesting guide. As you can see, this is like a tooth supported guide. We calculated how much bone we need. Also, as you can see here, this is the neuromuscular bundle here, right? So when we sit the guide here, we want to make sure we are not getting close to the nerve. We're always going to be above the nerve. We don't, even if we accidentally merging our macrosaw, we don't want to touch the nerve. That's why the bone harvesting guide is very important. It's very also accelerate the procedure too, because it's very fast. There is no guesswork. So as you can see in this video, before we harvest the bone, we're making a flap. We place that surgical guide over the area and we mark the whole area with the pencil. So what the pencil does, you can see there are like 4 cuts there, 2 vertical cuts, one on the front, one on the back, and 2 horizontal cuts. The lower one, it's usually above the nerve because we always want to be our safety zone. We don't want to get anywhere close to the nerve. And then there is a second one is like a horizontal cut. So we make sure all those cuts kind of like across each other for facilitating the harvesting the blood graft. All right, now as you can see, all 4 incisions are completed and we are ready to harvest the blood graft. We're going to use a chisel with the very controlled forces. We're going to go make a push outside, like a lateral push, and then as you can see on the video, we can harvest the blood graft. After harvesting the blood graft, the next step is to split it. We have to split the graft into shells. So that's a Khoury's technique. We have to use the shell as a shell technique, and the original graft that harvested is very, very thick. And we're not recommending to use that. Why? Because the penetration of the vasculars through that blood graft takes a longer time. And one of the ideas, the primary concept of the Khoury's technique is to create the vascular bed for our graft as soon as possible. That's why we split that. We're going to, as you can see, we're going to use the macrosci again, and we're going to split our blood graft in 2 shells. Whenever you have 2 shells, you're going to see one thin one, one thick one, and the thicker one, that's like, as you can see, I use my ronger and I use the scraper, and I start scraping, harvesting the autogenous bone chip. This is one of the most important part of this process. Why? Because this autogenous bone chip, they carry some growth factors. So those are the ones are in charge bone regeneration. As you can see, we're scraping it. We're gonna harvest that on you can see a container on the scraper, and then we're gonna keep those on the saline. As you can see, is a good amount of those autogenous bone chip we can harvest. So after harvesting that, then the next step is implant placement. Okay, why we place the implant before doing the bone graft? Because if we secure the graft, secure the block with the screws, those macro screws could be on the area that the implant should be. And we don't want that, because the implant should be on the area that we planned for it. So first we're going to place our implant. We're going to use our surgical guide that place an implant. As you can see, we place both of our implant. Part of the threads are exposed because of the horizontal bone deficiency. Some of them you can see it's not that much of the thread exposure, but the bone is so thin it will get exposed because of the pressure of the titanium, pressure on the thin bone. This bone will go away. So we know it in the beginning. As you can see in the video, these 2 implants, we're going to place them. After placement of the implant, the key point of the implant placement is the primary stability of those implants. So we would like to have about 20, 25 or 30 ideally of the Newton per centimeter of the primary stability of those implants. When the implant was placed, the next step is securing our blood graft around that area. When we're placing the blood graft, as you can see in this video, we use two macro screws to securing the blood graft, but because this is, as we discussed earlier, this is a very big graft. It's about 30 millimeter in a length. So I use 3 macro screws to securing this blood graft. Another more important factor for that blood graft is we have to make sure all the edges is smoothing out, no sharp edges, because that's creating the perforation in the soft tissue. So we securing the graft, we make sure it's 100% secure, no sharp edges on the graft, and the next step is using our autogenous bone chip to fill that area. As you can see, there is a void, there is a big space between the implants and our blood graft. At this point, what we're going to do is we're going to fill the whole void with our microchip, with our autogenous chip. And as you can see in this video, we pack it very hard. So the difference between this technique, the shell technique, and GBR technique, it's like whenever you use the allograft, I mean, we don't pack it too much. Why? Because we want to have some space for blood vessels to coming through. This one, we don't need it. I mean, it's a shell technique, it's autogenous bone. We don't need that space. It will already creating it. Number two is we don't need any membrane. Why? Because when using the autogenous bone graft, the primary concept is to create the blood vessels, the vascular blood for that area as soon as possible. If we use the membrane, we creating some occlusion for the blood vessels coming through. I mean, the most of the blood vessel coming from the jawbone, some of them coming from the soft tissue. So if we use the membrane, we will close that. We don't want it. So basically, packing the autogenous chip and no membrane. As you can see, we're packing it completely, and after packing, then the last part, which is one of the most important part of this procedure, is the soft tissue management. Why? Because we want to have a primary closure, and that closure should be tension free. Any early exposure, any tissue dehiscences, it will compromise the result. The 3.5 months follow-up, as you can see, you see a thick ridge here, the tissue is completely closed, and the x-ray shows the implant are getting integrated. And then what is the next step? The next step is the uncovering. So at the uncovering, we usually for that technique is about 4 months. So after 4 months, everything is ready. Implant was placed, bone is generated, so we're gonna move forward with the second stage. It's a very short procedure, 10-15 minutes, numb the area, open it up. As you can see in this photo, you can appreciate the amount of the horizontal bone being regenerated around these two implants. If you compare it to the first picture of them when we placed an implant, it was a very, very thin bone. No, we have a very thick shell bone around both two implants, and you see the bone is a vital bone. You see it's a red, it has the blood vessels on it,